All right, welcome to Dental Board reviews. So today we're going to be talking about amoxicillin. The last lecture we talked about the types of antibiotics, and so today we're going to talk about amoxicillin because you're supposed to know your amoxicillin for your dental patients. Okay. All right. So amoxicillin, amoxicillin, as we reviewed previously, it's a semi-synthetic aminopenicillin. Okay, and so as a semi-synthetic aminopenicillin, amoxicillin is not stable. Okay, to beta-lactamase. Remember, beta-lactamase are enzymes which are produced by bacteria, and they break down the beta-lactam ring of the penicillin. When they break down the beta-lactam ring of penicillin, the antibiotic is no longer effective. So amoxicillin works best in bacteria which do not produce beta-lactamase. Okay, so remember that. However, the benefit of amoxicillin, it's more stable. Okay, it's more stable to gastric acid, so you can take it by mouth. Okay, so amoxicillin has a good stability here. So you can take it by mouth, and when it's in the stomach, it's not going to disintegrate. Okay, it can still be absorbed. The Now, when you give amoxicillin, it has a very good bioavailability. Bioavailability meaning when you take it by mouth, it's going to be absorbed. Most of it is going to be absorbed into the bloodstream. Once the drug is into the bloodstream, that's called bioavailable. So it's available to start acting. Okay. So because it has greater bioavailability, it has low incidence of diarrhea compared to ampicillin. Also compared to other antibiotics. Okay. So penicillins and amoxicillin especially, it has low incidence of diarrhea. Why? Because it has greater bioavailability. So it is not going to stay in the stomach. It's going to be absorbed into the bloodstream, causing less diarrhea. Okay, and this is what I tell the residents sometimes. Okay, that amoxicillin has a broader spectrum. Okay, than than penicillin itself. So if you're going to have somebody who comes to your dental office and they have some swelling, and you think they need a root canal, so for the swelling to go down, you give them antibiotics. Go with amoxicillin. You can give penicillin V, but usually it doesn't have for the oral bacteria. For the oral flora, amoxicillin has a broader spectrum for oral flora. Okay, so the antibiotics you're supposed to know, especially if you're in the US, amoxicillin. Even when you're outside the US, amoxicillin, you're supposed to know what amoxicillin is, and also not just prescribing amoxicillin because you know it's an antibiotic, but you're supposed to know how it works and its advantages and disadvantages. Okay, because you don't want to be one of those doctors who the patient asks you, what does this antibiotic do? Why is it better than the other one? You should be able to say why you're giving that antibiotics and scientifically why, not just because you prefer to give amoxicillin over clindamycin. Okay, so you're supposed to have scientific uh, reason. So the use, why is amoxicillin used? So the amoxicillin is used mostly for, as you know, for dental abscesses or dental infections, and it can be used for coverage of sinusitis. Okay, for somebody who has sinus issues, and bronchitis. So if a patient has bronchitis, you can also use amoxicillin, but that's not the first thing to go to. But for sinusitis, you can use you can use amoxicillin. Now the issue with using amoxicillin alone for sinusitis is that in the sinuses you have H Haemophilus influenza, okay, H influenza in the sinuses. So usually influenza. So usually the H influenza has a beta-lactamase, so it will break down amoxicillin. So sometimes you give augmentin, which has a clavulanic acid. So yeah, we're going to talk about that later on. The other use, which you know is supposed to know for your board exams, is it is used for endocarditis prophylaxis. Okay, endocarditis prophylaxis, and for treatment of Helicobacter pylori infection. Now, it's not just for H. pylori infection. It's combined with other antibiotics such as metronidazole. Okay, amoxicillin is no longer recommended for use for treatment of gonorrhea. So yeah, you have to keep that in mind. Okay, so the mechanism of action, as we mentioned in the previous lecture, so the mechanism of action of amoxicillin is that it is a beta-lactam bactericidal. Okay, it is bactericidal, meaning it kills the bacteria. It does not stop the bacteria from growing, which when it stops bacteria from growing, that's bacteriostatic. Now this one is bactericidal, so it kills the bacteria. How does it do it? So it kills the bacteria. It is bactericidal, kills the bacteria by inhibiting the third and final stage of bacteria cell wall synthesis. Okay, so the amoxicillin inhibits the third and final stage of bacterial cell wall synthesis, and by preferentially binding to penicillin binding proteins. This is a very important slide. Make sure you memorize it, you know it really well, and review it. Okay, so it binds to penicillin binding proteins that are located in bacterial cell wall. So when it binds when it binds to bacterial cell wall, what happens is that it leads to fluids or water going into the bacteria, and the bacteria are going to lyse. They're lysis. They're going to explode. Okay. So that's how it causes the death of the bacteria. Now, for it doesn't break down. Amoxicillin does not break down the cell wall, but for the amoxicillin to work, because it's working on the cell wall, that cell wall has to be actively being formed. So the bacteria has to be dividing. Okay, bacteria have have to be dividing for the amoxicillin or the penicillins to work. Okay, so keep that in mind. If the bacteria are not dividing, these antibiotics are not going to work. The bacteria has to be actively dividing for these antibiotics to work. Now, when you want to to prevent the beta-lactamase enzyme, which some bacteria produce. Let's go back here. There's a point I want to make here. So remember, these antibiotics here, they act on bacterial cell wall. This is an advantage. So it's an advantage because human cells do not have a cell wall. We only have a cell membrane. So these antibiotics cannot inhibit human cell wall. Cannot inhibit human cell membrane or human cells to grow, because we don't have, as humans, we don't have a cell wall. But the bacteria have a cell wall which these antibiotics act on. Okay, so this is safe to human cells. Okay, so keep that in mind. All right, so moving on to clavulanic acid. Now, clavulanic acid has an advantage when you add it onto amoxicillin. Okay, because clavulanic acid has a beta-lactam ring. Remember, amoxicillin has a beta-lactam ring, and also clavulanic acid has a beta-lactam ring. So in bacteria which produce the enzyme beta-lactamase, the enzyme is going to bind the substrate, which is the antibiotics, the beta-lactam ring on the antibiotics, and break down the antibiotics, right? So to prevent that enzyme from breaking it down, you give amoxicillin and clavulanic acid, and the enzyme starts working on clavulanic acid. So they break down clavulanic acid, thereby sparing the amoxicillin. So the amoxicillin continues to work on the bacteria. So clavulanic acid is considered to be a suicide inhibitor. It doesn't really inhibit, but it's competitively it's competitive it's competitively it's competing with the active site on the beta-lactamase enzyme with amoxicillin. Okay, so it's competing with amoxicillin for the active site of the beta-lactamase. Therefore, it's committing suicide and causing amoxicillin to be spared, to be available to act. Okay, so make sure you understand how clavulanic acid acts. Okay, and so the other one, so even sulbactam is another beta-lactam drug also, which is mixed with ampicillin. So you can see sulbactam plus ampicillin. Okay, this is also a very good antibiotic that we use in the hospital. Okay, so again, clavulanic acid inhibits activity of beta-lactamase against amoxicillin. Okay, and clavulanic acid binds the beta-lactamase enzymes active sites, thereby inactivating the beta-lactamase. Okay, it has weak antibacterial effect. Something you need to remember. Clavulanic acid or clavulanic acid or sulbactam. Sulbactam, there's an L here. Sulbactam with a with a U. Sulbactam, okay, has sulbactam and clavulanic acid. They have weak antibacterial effects. Okay, very weak. And so, moving on about excretion of amoxicillin. So, amoxicillin and clavulanic acid are excreted in breast milk. So when you're giving it to a patient who is nursing, breastfeeding, you have to ask them whether they are breastfeeding. Okay, if you are going to prescribe them antibiotics. Even when you're about to prescribe a patient who just gave birth, you have to ask them whether they're breastfeeding, because you need to find out whether the drug you're prescribing is going to be expressed in breast milk. Because if it's expressed in breast milk and the child drinks it, then that's going to affect the baby. Okay, so if a patient has normal renal function, the half-life of amoxicillin is about 1.3 to and 1 hour. Okay, so 1.3 hours. So if you give 500 milligrams of amoxicillin, okay, that means in about 1.5 hours, half half is going to be eliminated. Okay, to 250. So remember that. And the clavulanic acid, in 1 hour, half is going to be eliminated. Okay, so make sure you know the half-lives of these medications. Now, when you give amoxicillin, when you give amoxicillin, 20% 20% of the circulating drug is protein bound. This is what I tell the students and the residents, is that 20% of circulating drug is protein bound. If it's protein bound, it means it can be carried throughout the body, but it cannot act. If a drug is protein bound, it's not active yet until it's free. Only free drugs are able to act. Okay, so that means 20% is protein bound, and therefore about 80% of absorbed amoxicillin is available. Okay, so that's why it makes it a very good drug. Now, amoxicillin is widely distributed into body tissues and fluids, okay, and excluding the brain and spinal fluid. So, however, when the meninges, so amoxicillin, you give amoxicillin, is not going to be readily to enter the brain, because the blood brain barrier, okay, caused by the meninges. But when the meninges are inflamed, the penetration of those antibiotics also increases. Okay, so, and also remember that in pregnancy, amoxicillin crosses the placenta. However, it's given, and it's usually safe in pregnant mothers. Okay, 60% of orally administered dose is excreted in urine. Okay, so urinary excretion of penicillin. So penicillin are excreted by renal mechanism. Okay, so 60% of the administered amoxicillin is going to be eliminated renally within 6 to 8 hours. Okay, and the concurrent administration of probenecid, remember that. So if you give amoxicillin and probenecid is going to prolong the elimination of amoxicillin. Okay, and in patients with normal renal function, the elimination half-life for amoxicillin, as we said, is about 1 to 1.5 hours. Oh, okay. And as we mentioned before, amoxicillin is It's very stable against gastric acid. Okay, so there are antibiotics which are not stable in antibiotics. Medications which are not stable in gastric acid are called gastric labor. Okay, and gastric stable antibiotics such as amoxicillin are rapidly absorbed. Okay, and the bioavailability, look at this. So a bioavailability of amoxicillin is about 74 to 92%. So that's very good. That's very good. That's almost 92%. That's almost like giving IV. IV is going to give you 100% bioavailable. But when you take by mouth, orally amoxicillin has very good bioavailability. Okay, and the peak concentrations. This is the reason why we use it for prophylaxis. Why the patient comes in and if they have heart problems that need to be prophylaxed, um, then you can give this medication because it reaches peak concentration within 1 hour, 1 to 2 hours after you take it by mouth. Okay, so patient comes to your office, they tell you about all these heart conditions that or they had history of endocarditis, then you can give them one two grams of amoxicillin, and you know that within 1 hour it will reach peak levels. Okay, usually it starts being bioavailable within 30 minutes. Okay, but it reaches the peak, the height, okay, uh, of concentration within 1 hour. Okay, and the special consideration for this is that if the elimination half-life of amoxicillin increases in patients who have renal problems, kidney problems. Okay, so make sure you remember that if patient tells you that they're on dialysis or they have kidney injuries or kidney problems, stages. So you don't necessarily need to know the stages of for this exam. You don't necessarily need to know the kidney problems such as stage 1, stage 2, stage 3, 3A, 3B, and from there you go to end stage renal disease. Okay, so however, you just have to know that because these antibiotics are renally excreted, if you have kidney problems, then those antibiotics are going to last for a long time. Okay, they're going to last for a long time in the body. So amoxicillin is prolonged up to 10 to 13 hours in patients with end stage renal disease. Okay, so you have to consider dose adjustments. Usually there are recommendations on the dosages that you can give. Okay, in patients with impaired renal function. Now, in neonates and infants, um, because the neonates and infants, they're still developing. Okay, so their kidneys are not well developed yet, so you still have to adjust their dosages. Okay, and so if you give the normal doses, it's going to the elimination half-life is increased in these young patients. Okay, so the dosing should be modified in pediatric patients. Okay, 12 weeks of age and younger. So what are indications to give amoxicillin? Okay, number one, cellulitis. Cellulitis, especially if it's caused by oral flora. Okay, you can give amoxicillin. This is so unless, let me repeat this, unless the patient is allergic to penicillins. don't give clindamycin just because you're trying to be safe. But if they don't have any allergies to penicillin, give amoxicillin, please. Give amoxicillin because as we saw, it has, for the oral flora, it has a broader spectrum. Okay, it's very effective for the oral flora. So patient comes in with a dental abscess and they don't have any allergy to penicillin, go with amoxicillin. Don't just give clindamycin. I've seen uh, a lot of patients who have been on clindamycin and still come back for 1, 2, 3 days, still come back with some swelling. Okay, which they were on antibiotics and the antibiotics didn't work for them. So clindamycin doesn't have as much of coverage for the oral flora as amoxicillin. Okay, but if the patient has allergies to penicillins, then you go to clindamycin. All right. So cellulitis, you can give it for dental abscesses, as I just mentioned. Okay. It doesn't matter whether it's periopical or just apical or even soft tissues abscesses. Okay. Most dental infection and dental alveolar infections, prophylaxis for endocarditis, as I mentioned. Okay. And also rheumatic fever prophylaxis. Now, the contraindications are those, as I mentioned, patients who are allergic to penicillin or they have penicillin hypersensitivity. So, in your exam, when you're reading these scenarios that they give as a story, pay attention to allergies that the patient have. Okay, because that's going to be very important on the treatments you render to the patient. So, if a patient also has a sensitivity to cephalosporins and carbapenems, remember, as we saw in the last lecture, these two cephalosporins and carbapenems are also beta-lactam antibiotics. Okay, so they are also beta-lactam antibiotics. So if the patient has allergies to or hypersensitivity to this, you have to be careful giving the penicillin, unless they tell you that I have taken penicillin before, amoxicillin before, and I didn't have any problems. Okay, so make sure you ask the patient about their allergies. The incident of true cross sensitivity. Okay, if a patient has allergies to cephalosporin or carbapenems, the incidence of true cross sensitivity has been to be estimated 3 to 5%. Previously, it was known to be about 10%. Okay, the incident. So you may see 3 to 5% or you may see 10%, if depending on whether the information has been updated. But currently, the cross reactivity for patients who are allergic to cephalosporin and carbapenems, if you give penicillin, they may react. That percentage is about 3 to 5%. So cross reactivity uh, percentage is about 3 to 5%, but previously known to be 10%. All right. So as we mentioned, if in creatinine, so the you are supposed to know what normal glomerular filtration rate is, but if your glomerular filtration rate is below 30 milliliters per minute, that means you are in end stage renal disease, and most patients will be put on hemodialysis. Okay, and for hemodialysis, you have to be careful on uh, prescribing a full dose of amoxicillin. So you have to consider adjusting your doses, because otherwise it's going to stay longer in the system. All right, So now the question is, you can say that what's the problem of amoxicillin stay longer in the system? It has an advantage that is going to work longer, but also it can lead to toxicities. Okay. So almost, another important slide here, almost all antibiotics, okay, almost all antibiotics agents have been associated with pseudomembranous colitis. Okay, pseudomembranous colitis usually is caused by the when you give the antibiotics, they're going to kill most of most of the bacteria in the stomach or in the GI system. However, the bacteria which is very hard to kill, and therefore it's called difficile. Difficile means difficult. Okay, it's difficult to kill is Clostridium difficile, and because it's difficult to kill with most antibiotics, this bacteria is going to grow in the GI tract, and it's going to cause inflammation of the colon. Okay, and therefore, because the colon is inflamed, it has lost its ability to absorb water, and because you have lost your ability to absorb water, it's going to cause diarrhea. So patients with pseudomembranous colitis, because of that inflammation of the colon from the overgrowth of of Clostridia difficile, present with diarrhea, and we're going to see in the following slides. Okay. Now, the bacteria itself does not cause the pseudomembranous colitis, but it produces a toxin, and this toxin produced by the Clostridia difficile is the primary cause for pseudomembranous colitis. All right. Okay. So if you haven't subscribed, make sure you subscribe to the YouTube channel Dental Boards Reviews, because we're going to be discussing very important information that you're supposed to know as a dentist, as a dental student, as an international dentist trying to pass your boards, because every dentist should know this information for their patient. Okay. So if a patient comes back with diarrhea after you give antibiotics, okay, a few days, a week before or after antibiotics, even if the patient has finished the antibiotics and they come back and they say they have diarrhea, start thinking the probability of them having developed pseudomembranous colitis. Okay, keep that in mind. So you have to prescribe the amoxicillin or any other antibiotics with caution to patients with inflammatory bowel disease. Okay, I have a patient who has currently I'm treating a patient who has uh, actinomyces. But before we did a biopsy, we, the we put on clindamycin. However, and that was clindamycin for 2 weeks, and I kept because I knew about what clindamycin is a culprit for, so the membranous colitis. I kept asking, let me know if you have any diarrhea. If you start, and when she told me she started developing diarrhea, we stopped it immediately. And at that time, the biopsy and the cultures have come back and it showed the actinomyces. So we switched to penicillin. Okay, and you're supposed to give penicillin for actinomyces. You're supposed to give penicillins for weeks. Okay, so make sure that you follow up with your patients if you prescribe antibiotics, and find out whether they're having diarrhea symptoms. Okay, and if they do, as I mentioned, so you make sure that you discontinue the drug if the patient tells you that they're developing diarrhea. All right. So Usually, amoxicillin, according to the manufacturers, amoxicillin should not be used in patients with mononucleosis. Okay, because it has a high incidence of skin rashes when it's given for patients with mononucleosis. So be careful. That's manufacturer's recommendations. Now, the antimicrobial activities, we are going to constantly review these in the coming lectures about antimicrobial activities, okay, because you're supposed to know what normal oral flora is and what type of antibiotics I need to go to, which one affects most of the bacteria in the mouth, and which one covers most of them, but not as much as the other one. So you're supposed to know these antibiotics. Okay. So amoxicillin is very good. Oh, okay. Has a very good activity against Enterococcus fecalis, E. coli. Okay. Hemophilus influenza. Remember what I was telling you? Hemophilus influenza commonly, okay, common is Hemophilus influenza, the one which is beta-lactamase negative. However, if the Hemophilus influenza is beta-lactamase positive, then amoxicillin is not going to be as active. You have to add clavulanic acid. Okay, so you have to give augmented. It's highly active on H. pylori, Proteus mirabilis. Okay, so, and then as we know, staph and strep. Okay, staph and strep species. Okay, so most common bacteria: staph, strep, Peptostreptococcus, bacteroids. Okay, so amoxicillin has good activity against all those things. All right. So the dosage that we commonly use, or that I commonly use, is the 500 milligrams every 8 hours. It says for severe infection, but usually this is the most of the patients we see uh, has infections which have gone into, if they, for example, they have a buccal space abscess, it has already progressed into the in the fascial planes. So amoxicillin 500 every 8 hours is very good. The other option is giving the 875, or you can give the 5 pill every 12 hours. Okay, or the 250 milligrams by mouth every 8 hours. Okay, so make sure you know your dosages for this antibiotic. In patients who are young, neonates, infants, then you're supposed to give. So you're supposed to measure their weight in kg. Okay, so if they give you the weight in pounds, make sure you convert the weight to kilograms. Okay, and to convert the weight in kilograms, if they give you pounds, is pounds. Okay, LB divided by 2.2, you get your kg equals to kg. Okay, so make sure if they give you 100 pounds, so make sure you divide by 2.2 to get your kgs. Okay, so now once you get your kgs, then you're supposed to know that amoxicillin in neonates or infants is supposed to give 30 milligrams per kg per day. Per day. Okay, so that means you're supposed to divide the dosage into every 12 hours. So divide the dosage into two. So if the patient has 100 pounds, so that's about let's say about 48 kgs, right? This is an estimate. I don't have a calculator, but this is an estimate. So if it's 48 kgs, then times 30, okay, times 30, that will give you that's 24 4 2 12 14 milligrams, right, per kg. Now you have to give this in 1 day, right, per day. So that means you divide this by 2. You divide by 2. So if you divide by 2, it gives you what? About, so if you divide by 2, that's 2, 7, about 750. Okay, about 7 is sorry, it's not 750, but 720 milligrams for a patient who has, for a child who has 100 pounds. Okay, every 12 hours. Remember, you're supposed to have to divide it. Don't forget to divide it. So just remember the calculations. So if when you're giving in children, they're given per weight, okay, per weight per day. So amoxicillin for treatment of dental infections, including dental. So, and it can be used also for adolescents with aggressive periodontitis or refractory chronic periodontitis with combination. Now, for aggressive periodontitis, you give amoxicillin plus metronidazole. Okay, very good combination after scaling and replanning. And how much do you give? You can give amoxicillin either 250 to 375 every three by mouth 3 times daily, with metronidazole 250 milligrams 3 times daily for 7 days. Okay, this is patients with aggressive periodontitis or refractory chronic periodontitis. All right, very important slide. All right, and also it can be given. Amoxicillin can be given for acute dental abscesses, as I mentioned before, and even after you do a surgical incision and drainage, you put the patients on antibiotics. Uh, you can do a loading dose. So usually when the patient comes in the emergency room, we establish an IV and tell the emergency room to give a loading dose. Okay, because sometimes you give a prescription to the patient and they don't actually feel it until the following day. But if you give them a loading dose, you can start having those antibiotics start working. Okay, and so a loading dose, I can give 1 milligram PO as a loading dose, um, and then you can prescribe them the 500 milligrams 3 times daily for 3 days. But usually you need it for 3 days because that's the how long the inflammatory process lasts. But most dentists and physicians go with 7 to 10 days. All right, and for the other use is as we mentioned, amoxicillin is given for patients with uh, endocarditis or history of endocarditis, bacterial endocarditis, of course. Okay, so patient comes in and they tell you they have a history of bacterial endocarditis, or the patient won't tell you, but their physician send them to you because they have dental problems and they have seen that there's some vegetations on the valves. Okay, and so if they're planned for valve surgery, then you want to give them also, because of the bacterial endocarditis, you want to give them 2 grams of amoxicillin by mouth, PO, okay, as a single dose, and you can give it 30 to 60 minutes before the procedure. So within 30 minutes, you can start doing your procedure. And the conditions, these are the conditions. So another important slide, the conditions that you're supposed to prophylax, okay? The conditions that you're supposed to prophylax is one, patients with prosthetic cardiac valves, all right, and patients with history of previous infective endocarditis, and patients with certain or select, okay, it's not all patients with congenital heart disease, but it's patients with certain certain congenital heart diseases, and also patients who have a history of cardiac transplant with valvulopathies. Okay, so make sure you know which conditions you're supposed to prophylax. The Now the dosage for children. Okay, the dosage for bacterial endocarditis prophylaxis. The dosage for prophylaxis for children with history of endocarditis is supposed to give 50 milligrams per kg, okay, by mouth as a single dose. So, but you have to go to the maximum of 2 milligrams. So, if your calculation, if your calculation if the for example the child is overweight and you calculate based on the kg or the weight, and you realize that you're going to give 3 milligrams of amoxicillin, don't give the 3 milligrams. The maximum you can give is 2, so give only 2 grams. Did I say 3 milligrams? 3 grams. If you calculate that you're going to give 3 grams, which is 3,000 milligrams, only give the 2 grams, which is equivalent to 2,000 milligrams, okay, before the procedure. So the FDA classification in terms of teratogenicity of amoxicillin. So amoxicillin is considered to be a risk category B. Okay, so meaning it's considered safe during pregnancy, even though you have to be cautious, but it's considered safe to the fetus. Okay, so make sure you know the category of these medications. So pain medication for pregnant patients, usually Tylenol only, plain Tylenol, and antibiotic medication for pregnant patients, usually amoxicillin. Okay, those are safe. So a pregnant patient who's in pain, you can ask them to take Tylenol. A pregnant patient who has some infection, you can give them amoxicillin. Okay. So amoxicillin is, remember what I was telling you before. Amoxicillin is excreted in breast milk, okay, in small amounts. So if you're if a mother is breastfeeding and the baby start developing in the mouth, a week later, you realize that the baby has a white coating on the tongue. That means the antibiotics have killed most of the bacteria in the baby's mouth, and there is a fungus growing. So candidiasis. Okay, so make sure that a mother who is breastfeeding, they can monitor, and if they notice white coating in after days in their infants in the baby's mouth, then it means there's some candidiasis due to the antibiotics. Okay, or the baby can develop some skin rashes. So always tell the mother to watch out for these things when the mother is breastfeeding and they're taking antibiotics. So interaction with birth control. So this is another thing that if you prescribe antibiotics, and especially to young females, females on birth control, you always have to tell them that they can start you either use barrier method for the period that they're taking antibiotics. Barrier method means condoms, or they can double the dosage Okay. However, those are the known ways. Okay. However, there's a lot of research has shown that you don't really need to change the dosages of over oral contraceptives when the patient on taking antibiotics, but because the consequence, because even though the research shows that there's no actual significance, okay, on the interaction of amoxicillin with birth control. The still the experts recommend that you warn the patient that the birth control may not the oral contraceptives may not work well when taking antibiotics, because the risks of getting pregnant uh, uh, may outweigh the benefits. Okay, so for example, if somebody gets pregnant and they do not want to get pregnant, that's a serious consequence. Some people don't want to get pregnant at certain times. They want to have, to be pregnant when they have planned it, but they don't want to have something accidentally happen. Okay, so the recommendation is just to go ahead and warn the person to use barrier methods or double the dosage of over the counter. Sorry, not over the counter, but oral contraceptives when they are taking uh, antibiotics such as amoxicillin. Okay, so the combination of amoxicillin with clavulanic acid is called augmentin. Okay, I love these antibiotics. Okay, this antibiotic is very good. Uh, it has it's an excellent drug. Okay, I love augmentin. The advantage, now remember, advantage of amoxicillin is that it's cheap, it's affordable. Even patients who don't have insurance can afford amoxicillin. Augmentin, when you give augmentin, it becomes expensive. Okay, although if it's an excellent drug, it's very expensive. But amoxicillin is cheap. Okay, so you have to make sure that the patient can afford the drug that you're prescribing. All right. And some of these things we've already mentioned, the activity of clavulanic acid. All right. So just review it quickly. And this is the end of it. Okay. And make sure you subscribe to Dental Board Reviews. And we're going to be talking more in terms of some of clinical scenarios. Okay. All right. Good luck and study hard. Let me know if you have any questions.